Hello everyone, I'm Dr. Evandro Diniz from Belo Horizonte, Brazil. It's a great pleasure for me to be here, at least online, for this great event, OFTALMO CORDOBA, International Ophthalmology Meeting. I would like to congratulate all the directors and everyone in the organization, and I would like to make a special thanks for Tiziano Giobellina, a great friend of mine. Thank you for the invitation. We're going to talk about how we can improve our results with the implantation of intracorneal ring segments. I have no financial interest in the presented products, but I do have some research grants. But before we go ahead and talk about the surgery planning, it's important to establish some information about keratoconus. It is a multifactorial disease, and its variability in presentation and evolution is huge. Influence on visual acuity and, for that matter, influence in the patient quality of life, it's a very important thing. And it is indeed a stage-dependent treatment disease. So we have to carefully choose each treatment for our specific patient. But as long as the surgery is indicated within the established criteria, variability of the result can be reduced by improving the surgical planning. So surgical planning is the key. What are all these established criteria? Low best corrector visual acuity, poor adaptation to hard contact lens, or even inability to wear them, no corneal scars, at least 4 micron corneal thickness on tunnel pathway. And we do have some variation about what we believe it's the highest keratometry value we should treat, but it's a little bit controversial. But as long as we perform a safe surgery with safe corneal thickness for the implantation, we have a go. But intracorneal ring segment is not a refractive procedure, even though it does have some refractive impact. It is important that both doctor and patient are aware of that. We cannot forget the classical postulates of Blavatskaya and Bahaker, so we can comprehend all the mechanism, the effect of our ring segments. And to understand that, it's important how each one of them act modifying the shape of the cornea. We have the shorter length segments that have a great potential to correct astigmatism, but do not flatten the cornea that much. And in the other hand, we have the higher or the longer arch segments that have a great effect flattening the cornea and may have some effect correcting the astigmatism as well. So how can we improve our results? Planning. Like I said, planning is everything. So we can customize our surgery by our planning, by choosing the right segments for the right patient. The previous nomograms that the manufacturers provided, and I say with previous nomograms, all those until 2018, they were pretty good. You know, if we ask our colleagues if they worked, yes, they did, and we have proof of that in this great paper by a friend of mine in Brazil, Dr. Guilherme Rocha, that compared the results of the manufacturers' nomograms provided by 2 manufacturers, and they all worked good, in a good way, and they all worked in an equal way. They were similar in the results, with a tendency of a better topographic astigmatism correction towards the nomogram provided by Medficus. So the previous nomograms, what are the weak points about them? They were limited to only one or few variables. They did not include neural implants. and they did not incorporate all the parameters of all the great equipment that we have in our hands and in our clinics. But most important, no defined criteria for cases where there are discrepancies between the refractive, topographical, and coma axis. The new nomogram that we're going to talk about a little bit has been clinically in use since January 2018 and has been adopted by Medifacal since then. A prospective validation study is currently in progress at Banco de Olhos de Sorocaba, and it's a part of my PhD project. Newer implants, like long arc length, the asymmetrical segments, are also considered in this nomogram. And it incorporates multiple parameters available in modern propedeutic equipment. And it does have a defined criteria for cases that there are discrepancies between the refractive, topo, and coma axis. But what do we need to start planning? Regular data that we're usually familiar with, like visual acuity, refraction, corneal tomography, the coma axis and the coma magnitude, and pupil diameter. And with all that information, we're going to perform a morphological classification that has been established by Professor Alfonso and Fernandez Vega. And the important information to summarize what we do need to know in order to do this classification is refraction, flat topographic and coma axis, steep keratometry and mean keratometry values, and to analyze the topographic regularity and symmetry of our patient. With all that in hand, we can classify the keratoconus in 5 types. For most of these types, we have a great amount of agreement between specialists in order to choose some specific segments. But for specific 2 types, type 2 and type 3, every time we discuss the case with that morphological classification, the disagreement rate was higher. So the idea of this nomogram is to provide a better way of planning, and even for the unexperienced surgical as well as for the experienced surgeon. So an example for type 3, the so-called muñeco de nieve, or snowman, if mean keratometry is below 52 diameters, we're going to go with 2 ring segments, 2 asymmetric segments. So we can correct in a greater manner the steeper or the steepest part of the cornea, the ectasia, down below. Here's an example of a patient that had a best corrected visual acuity with contact lens of 20/30. So we implanted the 2 segments, and the surgery is performed in a regular manner as we used to, with regular arc and regular thickness segments as well. We do not change the technique. And this patient, after the surgery, achieved an uncorrected visual acuity of 20/30, and we can see, and it's important to call attention for that the asymmetric segment did provide a greater correction where it is thicker. So it makes all sense when we remembered about the Professor Barraquer postulate. But if we have the same kind of morphological classification, but the cornea is steeper and the mean keratometry is above 52 diopters, we're going to go with a long arc segment, a 330, but also asymmetrical one. So it's thicker at this bottom part of the segment. So we can achieve a greater correction as well. So this patient we implanted this kind of segment, the 330 asymmetrical one, and we did have a greater correction right here with excellent visual acuity result. Here's the slit lamp video recording of this patient, and it's a very beautiful segment as well. It does have a difference for when we compare to the regular thickness. Long arc segment has this rain trance right here to make a difference, so we can notice that it's a asymmetrical segment. For the type 4, just to call attention, we usually agree, so we're not going to go into that, but it's the regular long arc segments, the regular ones, no asymmetrical thickness along the arc. But the type 5, we do have a special segment, the so-called sinusoidal arc segment. It's thicker on the sides, not on the bottom part, in order to also flatten the cornea in a greater manner, but keep the potential to correct the astigmatism, the topographic astigmatism. We have less experience with this kind of segment, but we are seeing in our study great results with it. All of this is available online, so you can check online the nomogram. It's if I'm not mistaken, it's KERATOCONUS online. You can have the whole nomogram to access and start doing your planning. And what are our take-home messages, our final words, sort of speaking? The important thing to know is that the inclusion of multiple parameters in the surgical planning allows greater customization, minimizing errors and enhancing visual outcomes. And the nomogram that does include such parameters allows even the least experienced surgeon, as well as the most experienced surgeon, to achieve better results. Of course, further studies, including comparative analysis, should be undertaken to better understand the benefits of new segments and different nomograms. And what I believe we'll see in the future. I believe that customization by finite element modeling of the patient's cornea and the simulation of postoperative results with different sizes and positions of implants may help us a lot. The technology already exists and is in clinical validation. It is still a slow and expensive process, but as well as any other technology, it must overcome these barriers. Truly customized implants manufactured by 3D printing should help us a lot, customizing and producing a customized segment for that specific patient. I hope that what we talked about here helped you to start thinking about planning surgery in a different way, considering multiple parameters and customizing your surgery for the best benefit of your patient. Muchas gracias. Thank you very much. Obrigado. Hope to see you all next year in Cordoba.